Thank you, Madam Chair. I appreciate you allowing me to come and testify today. Also, your co-chair, Representative Ritter, Ranking Member Srinivasan. I'm here to talk about Senate Bill 352. I handed in some fairly detailed written testimony, so if I could just maybe highlight that and then entertain questions with your permission. Thank you, Madam Chair. As you probably know, the Department of Consumer Protection, through its Drug Control Division, has been involved in preventing drug abuse, addiction, and overdose for a long time, long before this really horrific opioid epidemic. We're working with our sister agencies. It was good to hear from both of the Commissioner Delphin Ritter and Commissioner Pino. As a matter of fact, we got another email from Commissioner Delphin Ritter about kind of coming back together to view how we're doing things in a collaborative fashion. It's a horrible public health crisis out there, and it's impacting families everywhere. Nobody can escape it, and I have to tell you personally, my brother-in-law died of a heroin overdose 5 years ago in June. So I understand the stakes out there. And I want to commend the proponents of Senate Bill 352 on their intent. I think it shows that people recognize the problem, and it shows that everybody wants to help with solutions. Before I comment, I just want to sort of clarify what has been ongoing, and that seems to be a kind of confusion with terms. With respect to OTC, over-the-counter, and Chairman Ritter, you asked a very good question about Walgreens. I think in part because of the way that press release was written, it sounded like over-the-counter. In fact, you cannot have over-the-counter sales of naloxone, Narcan. It is, while not a scheduled drug, it is a legend drug, and it is against federal law to actually sell that over-the-counter. The model that Walgreens is using, and I think the underlying intent here, is through what's known as a standing order. We know them most commonly in a flu vaccination, a flu vaccine, where there's basically one macro prescription that's written, could be by one doctor, and that in that flu context enables the pharmacist to actually administer, in that case, not dispense like with naloxone, but administer the flu vaccination. So it's important to keep those things separate. And I will say and highlight later that when it comes to a standing order situation, in most of the states that have adopted that model, pharmacists are still required to be trained. And that's a key part of our bill, too, that was passed last year. So why don't I get into that? Because that's our issue with Senate Bill 352, is that it unnecessarily and unproductively interferes with the current policy that you all passed last year. We now have a system that's set up similar to one in California, where it's a pharmacist prescribing model. So the pharmacist is able to write the script and basically dispense the naloxone to the loved one, family member, friend, the caregiver, we'll call them. Under this model, the pharmacist has to be trained and certified to prescribe and to dispense. It is designed to take advantage of the key position that a pharmacist is in our healthcare system, that face-to-face, one-on-one contact with patients, with family members that are coming in. And so this training is not just, which can be fairly simple, showing that person how to deliver, to administer the naloxone. It's much more holistic, because we really don't want to have to administer the naloxone. That's like the last case scenario. What this does is, in addition to that training, it gives the caregiver training in best practices in an overdose situation. Because remember, these are not, ordinary situations. There is a serious life and death occurring here, and to be able to give people best practices, turn the person on the side, what they need to do to control that situation, the order of things is extremely, extremely important in that case. Moreover, the training is designed to help the pharmacist be able to connect with, speak with the caregiver who is obviously seeking help as a direct conduit either to the actual patient, if the patient's there, or to their loved one to get them into prevention services, to network with all of the prevention and recovery services in the area and try to get them to those services. Because remember, naloxone administration is the last thing you want. You want to prevent someone from getting into that crisis situation. As a matter of fact, my brother-in-law, he was alone. So that wouldn't have made a difference if naloxone was even in his house. That being the ultimate goal, I also wanted to make one other important distinction with our system currently, is that the idea of a pharmacist being at the helm through the prescription drug management program, being able to see someone's prescribing history, that common interaction that we all have with our pharmacist, they're able to actually sometimes spot an issue when somebody's coming in to get somebody else help. As a matter of fact, recently I heard of a situation where a husband was coming in to get prescriptions for his wife who was suffering from cancer. Because of the toxicity of the cancer regimen, the drugs, she actually overdosed and had the naloxone because the pharmacist was proactive in that situation and was able to handle it. Remember, it's not just, even though we're focused on it, it's not just about the opioid epidemic. There are other benefits that this particular system helps. This program is growing. There are now 160 pharmacists that are trained and certified. Within the next couple of weeks, there will be, the chains will be on board. It's likely that one, I believe CVS, will have everybody trained, a large number, and certified within the next month. So more and more is happening to make this grow. So I don't oppose the intent of Senate Bill 352, but I think that it is premature. Remember, this is a crisis, and while we need to act, we also want to act in a well-thought-out way that actually helps get our arms around the larger problem. There is a growing number of pharmacists that are prescribing. Docs still can prescribe for naloxone. First responders many carry naloxone, and there are efforts to step up on that. So it is available, and I guess let's not do something that might hinder a larger type of focus on getting solutions to the opioid endemic and saving people like my brother.
Srinivasan. Thank you, Madam Chair. Thank you, Commissioner, for coming here this afternoon and for your testimony. And most importantly, perhaps sharing your very personal story with all of us today. Two things that among the many things that you talked about, two things that I wanted to just have the opportunity to discuss further with you. Your concept of the pharmacist being at the helm of the affairs as far as medicines are concerned, giving advice and interacting with the people that walk in and out of the pharmacy. That was how it was many, many years ago, 20, 30 years ago. In Glastonbury, we had two beautiful pharmacies, and we all went to either one of the two. And not too much on a personal basis, but the pharmacist really knew you and knew all the people that walked through his doors. And those were the good days. So the scenario that you're saying, where the pharmacist is able to advise and educate and the people that walk through, that was what we had. That was the system we had. But unfortunately, with big box coming in and they're replacing what we have, number one, and number two, the mail orders. So where half the time we don't even need to go to the pharmacy anymore, other than the rare times on an acute basis. That rapport, that connection that every person had with their town pharmacy doesn't exist anymore, or at least doesn't exist in most of the towns, including in a town like Glastonbury, which had that in the past. So that's a concern because there's no longer, I'm not saying it's a 9 to 5 job, but there's somebody who comes in, puts in the hours, puts clocks in, clocks out. So that relationship doesn't exist, unfortunately, anymore. So that makes it a little more demanding in a very complex situation where advice needs to be given in these kind of situations. So with that in mind, the training that these pharmacists get to be able to counsel, to dispense, and then obviously to record and everything else. Let's say, for example, in the CVS pharmacy in my town, where I go to in Glastonbury, there are about 10, 12, on an average, about 6 or 7 people behind the counter. Obviously, I don't know who's the pharmacist and who's the helper. So with this particular job of this particular being able to dispense and all of that would only be by the pharmacist, or could he or she in turn be able to delegate to the other people, or why don't you give this prescription to this person? That's my concern in this prescription process.
The way the system is currently set up, it's the pharmacist that actually prescribes, and the pharmacist is the front line of dispensing the drug and talking to the caregiver, the patient. You bring me back a long way, Representative Srinivasan, because I worked at Bishop's Pharmacy, a mom and pop at Bishop's Corner, had a lunch counter. I actually did a little short order cooking for a while too. But that was a much personal time in a lot of ways. But I will tell you that even at the CVS, which is my corner drugstore now, I have interactions with the pharmacist when I go in, and there's a particular place, and I still do that. And now we would like to try to move back towards that more face-to-face holistic model. Now you have some technology like the PMP that through information is able to kind of help bring those connections together. So while I do think you're correct that we moved away from that, it's still there, and the goal is to build that type of interaction so that we have numerous gatekeepers and people that are healthcare providers out there being a part of the problem. You're never going to deal with the opioid epidemic by slicing off pieces. And while I know, Madam Chair, that this isn't intended to dismantle the program, my concern is that it could sort of smother it by changing the model right when there's getting traction on what I believe is a more holistic model that ultimately will help us save lives.
Thank you, Commissioner. And one final question, if I may ask, if you can just walk us through a scenario where a family member would just walk into a pharmacy and then just request the pharmacist? Is that how that would work? Because obviously that's not how we do it. So it would be an education in itself. People, go in with a prescription or go there to pick up a prescription, as opposed to going there and asking, quote unquote, for a consultation, and obviously with all the necessary privacy and everything else. So is that how you envision that would happen?
That's how it is working. In fact, I think that the benefit of this is it is more accessible than having to go to a doctor. It obviously allows the prescription to be written to the caregiver, so the third party there, and it's in a place where people are commonly asking questions of the pharmacist about various drugs and interactions, both with what they're taking, what they may take over-the-counter drugs. So that type of conversation is common in the pharmacist setting. So I think it's also the environment that it's in is also conducive to having people participate with pharmacists.
Thank you, Commissioner. Thank you, Madam Chair.